I work with Dr. Richardson through the Scleroderma program. I also am in the interstitial lung disease program. You'll meet Dr. Selvan next. I run our scientific and translational research program there, and I'm very, very happy to come and join you guys today. So a little bit of objectives for today. So we're going to explore the role of AI in your modern day activities and how the society has really kind of evolved in thinking about AI. We're going to define what it actually means and look at some of the subcategories that you might hear about. I just want you to get these words in your head. I don't want you to really kind of walk away and be able to tell me what machine learning is, but I just want you to know what that word means when you see it in kind of the popular literature or anything that you hear on the news. I want you to appreciate the complexity of applying these techniques that I'm going to talk about today and how we use them in healthcare to try to improve your care. And finally, I want to show you some of the data that we've actually collected from probably some of the people in this room to kind of see where we're moving forward at Northwestern to use patient data to help move your care forward and actually prevent some of the things that Dr. Richardson had talked about that may happen to you. Okay, so let's have a little bit of fun here and talk a little bit about the perception of AI and the utilization of AI throughout the ages. So, let's talk about very, very early. AI was seen in popular culture as kind of like the boogeyman. I mean, Halloween's coming up, right? So we have to talk about this guy. So in the early 1800s, Marie Shelley wrote this book, Frankenstein. It's a scientist that made this like just monster, right? The sentient being with disastrous results, and so really kind of depicting that something that is not human might actually be able to cause a lot of problems for us. Then kind of in the early 1900s, there was these machines that were depicted in this movie that came out called Metropolis, based off of a book. It was this machine called Maria, and she kind of incited chaos. And this kind of brought to the cinema a lot of distrust in AI, and you've probably seen this kind of perpetuated throughout movies. A lot of you probably have seen this movie, 2001: A Space Odyssey. This came out in the late 60s. There was a robot in this movie, HAL 9000, that basically was murdering a bunch of people. It really started this trope that AI can be made to program to do good, but then basically kind of flip on us and actually do some kind of destructive programming, even though we programmed it to do well. We'll move on a little bit to the 70s, kind of the early 2000s. You recognize this guy right here, Star Wars in the late 70s, R2-D2, my favorite robot. This guy kind of flipped the script on what we saw earlier. This kind of really brought AI to the front and show that AI might actually be capable of living with humans, and they might actually be able to be heroic. You might have seen the movie Blade Runner. This is Joanna Cassidy depicting a character in there called Zora. She was what was known as a replicant in the movie, and basically they were going around and killing these artificial humans. And it really kind of brought this question of what does it mean to be human, and what is consciousness, and a lot of philosophical questions about what does it mean to be alive and be human. And then, of course, we can't talk about AI without talking about this guy right here. So, in the Terminator, there was Arnold Schwarzenegger. Obviously, he was part of this, this force called Skynet. It was basically a self-aware military defense network that was creating a nuclear holocaust to kind of eliminate humanity. And so, there's lots of shifting perceptions throughout popular culture, starting out the boogeyman, maybe, a little bit of, fun with R2-D2, but then also still kind of a negative perception. Switching to the early 2000s, now we're kind of really thinking about, kind of to President, where's the boundaries between humans and AI, and how can we relate to each other? So in The Matrix, coming out actually in the late 90s, they've explored a virtual reality. It it looked at the potential for AI to like enslave humanity or break free from its program existence. And this obviously, this was a kind of people were plugged into this program and thought that they were actually living, but they actually weren't, and they were enslaved. This movie, Her, came out in the 2010s, and this is kind of like AI is a reflection of ourself. Joaquin Phoenix here actually fell in love with a programming system, an advanced operating system, and it kind of explored this genuine, deep connection that humans can potentially have with non-human intelligences, normalizing AI as part of your everyday life. Again, kind of shifting relationships with humans and AI. We have Matrix, where they were trying to destroy us, and we have this Her movie where he basically fell in love with an operating system. And then finally, Ex Machina. This came out in the 2010s as well. There was an AI character in there depicted here. Her name was Ava. She was very convincing, very manipulative, that she kind of blurred the line between what it meant to be human and machine. And the protagonist in this film really had a really hard time dealing with the perception of this being and the ethics behind it. Lots of ways that we've kind of thought about AI throughout our time as humans and as it's evolving. But what I want to tell you is that AI is actually everywhere. You may not know it, but AI is literally everywhere, and you guys use it every single day, and you probably may not notice it. So let's look at a couple things. So technology and entertainment. So if any of you use Instagram, Facebook, Spotify, Netflix, you know that on there they're going to recommend things to you, right? They're like, oh, you watch this movie, you might like this movie, right? So basically, this is a way. It's actually an artificial intelligence system that they use to look at what you've actually already watched and predict what you might like. And that is actually artificial intelligence. A lot of you probably have an iPhone sitting in front of you. It has Siri on it, right? There's virtual assistances. And so they kind of help you navigate your everyday life. Services. So if you have an email client on your computer, you probably have a spam filter on there, right? So sometimes the spam filter does not catch what actually is spam, and you tell the system, hey, that's actually spam, and it learns. And so that's artificial intelligence running in the background of your email. Google Maps and other kind of navigation systems, they can kind of reroute you based off of traffic. That is also an artificial system, and then Amazon uses it probably at every single step of the way. You pop onto Amazon and you've bought something. Sometimes people think that it's actually like listening to you because like you're like, I just talked about that, and all of a sudden it's like trying to sell me it, right? And so it's a way to kind of really get products that you have might be interested to you right in front of you. And then finally, we also use it in business and finance. So you probably have gone somewhere and used your credit card, and then they say, hey, it's declined. And then you get a text on your phone, and it says, was this you? That's actually AI through places like Bank of America or other financial institutions, looking at things that you've bought before or places you've been and saying, that doesn't look like that's you. Let me just make sure that's you. And so that's been used as well. Fraud protection, customer service. So this drives me nuts, right? Like you call somewhere and you have to like sit there on the phone, right? And you go through all these like different, like you push 1 for this and push 2 for that. And then basically sometimes you even get an answer from the machine. And so that's actually an algorithm and an AI system that kind of brings you through customer service. Other things, this was weird to me. I went to San Francisco and saw this. So this thing called Waymo. So I think they actually might be coming to Chicago, to be honest with you. This is a self-driving vehicle. It's a taxi system. It was in San Francisco. They're actually really cool to be in. But like it basically it's like an Uber that it self-drives and can detect traffic. It can detect humans like in the sidewalk and stuff like that. And so that's another place that you might see it in today's world. This is basically, it can detect, on different social media that you might have, like it can find someone's face and say, hey, you know that person. You might also know this person because they were in a picture that they took like 3 days ago. And so it really kind of can connect you to that. And then also voice recognition systems. These are getting more and more kind of like language, like text to speech and all that stuff. So AI, I just use this as an opener to tell you that even though AI has been depicted kind of really poorly in modern culture as like being destructive, we're already using it, and it's already here, and we really just have to learn how we can adapt as a society to kind of really coexist with these systems that are kind of already here. So now we talked a little bit about some examples of artificial intelligence. We walked through a little bit of the movies that have kind of depicted as like these horrible things, and then how we're using it today. So what exactly is it? So when I think of AI, it's kind of an umbrella term for multiple different computer models. And so AI is like this big term. And what AI actually is, if you look at the definition of it, it's application of a computer system to perform some tasks or produce an output that normally requires some kind of human intelligence. Okay, so for example, in Spotify, right, we talked about how you listen to a song and you have like multiple songs that are kind of similar. Your friend might be like, hey, you listen to that song, like you might like this song, but artificial intelligence actually can perform that task for us through a computer system. Machine learning is what we typically use in research. It's a subset of AI, and so it's basically developing these computer systems that can learn and adapt by following instructions, by using these algorithms and statistical models to analyze and draw inferences. So when I say the word inferences, you'll hear that throughout my presentation today. I mean conclusions from patterns in data, okay? And that's one of the most powerful tools that we have right now to use artificial intelligence in healthcare research, because we're trying to draw patterns between patients and outcomes, and that's a type of machine learning. We get even deeper into something called deep learning. I'm not going to talk about this today too much, but this is a subset of machine learning. So it's basically like multiple different machine learning algorithms that have like, I think of it as like multiple different like human brains, like systems. They call them like neural networks. So it's like a bunch of like different types of human brain like models that are talking to each other, and so it kind of creates this like multiple layers of artificial intelligence that can give us even more information. And then finally, we have something called convolutional neural networks. We're using this at Northwestern. Actually, that's the next step of the project that I'm going to walk you through. But this is specifically used to analyze visual data. And we use this in my group to look at CT scans that I'm pretty sure a lot of the people in this room have had before, to try to find patterns in kind of imaging. And so taking from this slide is that artificial intelligence is this big word that people like to use, but there's just multiple different layers of it, and it can have different meaning depending on the context. So, I'm not going to lie, that I talked about some of the benefits, but there's obviously limitations, and we're going to look at a couple of the things that we think about in healthcare. So, in healthcare, in many different fields, we've seen that this can lead to early detection and accuracy of diagnosis of disease. This has been shown many times in different ways, particularly when you hear Dr. Selvin talk in interstitial lung disease. We've been able to show that sometimes the computer is better than the radiologist at picking up different patterns. We've also used this to enhance patient outcomes. That's some of the data that I'm going to show you. So trying to tailor therapy towards patients based off of patterns and data that we're seeing in patients' records. It also has been used to increase efficacy and cost savings. Nursing uses this, administration uses this to try to really kind of streamline healthcare delivery, so that we can do this efficiently and at the least amount of cost for you. And then support for clinical decision making. I have, when I open my dashboard and when I'm seeing a patient, there's multiple different things that pop up and like different percentages. Particularly, I was just attending in the ICU, there's this little thing that's like a percentage that pops up that tells me whether or not the patient, if I discharge them from the intensive care unit, would be likely to come back. And it gives me like this percentage. I have no idea how that works. This is proprietary mechanism, but and quite honestly, I don't look at it, but it is an artificial intelligence system trying to tell me the risk of that patient coming back to the ICU, and that's kind of supporting my clinical decision making. Does have its challenges. Data privacy and security. We're putting patient data into a machine algorithm and asking it to make patterns and inferences. And so we have to be very, very careful that when we're putting that data into a artificial intelligence system, that we're de-identifying our patient's data and that the output cannot be linked back to our patients. Sometimes these algorithms can be very biased, and we're very aware of this in the research world. One of the ways we try to get around this is that, so let's say I'm studying scleroderma outcomes in patients in Chicago. Chicago may look very different than New York. It might look very different than Midwest America. And so what I might conclude based off of my research may not be applicable to the rest of the country. And so we tend to try to validate these models in different populations so that we don't bias our clinical decision making to the people in this room or Chicago in general, and we try to bring this more generalizable outside there. It can be integrated with existing clinical workflows, but sometimes it's a little clunky, and it actually adds a little bit more, a couple of clicks for us. And so sometimes it can be challenging in integrating it into my day-to-day activities. And I brought up the example of the ICU with that percentage that pops up that I have no idea what to do with that. And so it's really hard sometimes to really think about how we can integrate that. And then there's regulatory and ethical considerations, right? So we've talked about some of that through the modern day kind of way we've thought about AI throughout the ages. Okay, so how do we develop AI to improve healthcare? So this is where it's going to get a little bit technical. I apologize. I don't have really cool models like Dr. Richardson did that all broke. But I want to kind of walk you through how we think about AI when we think about improving your healthcare. So this is kind of a roadmap then when we think about AI. So these little kind of stacked things here. This is how the literature depicts a database. These little stacked things. So we have a database here. This database is very messy a lot of times, and what happens is that, for example, in our project, we have patient data that is coming through, and it's all kind of sometimes you miss a decimal point someplace, or you enter an extra zero, or the date is wrong, or the CT scans were done for one patient at 1 month, but the next patient was done at 4 months, and how do I tell the difference between that 1 month and 4 month? How do I line them up and make sure that I'm accounting for time? And so really that cleansing that data takes a lot of time. In fact, for the project I'll show you, it took us 2 years to get that data really cleaned. And then we end up with a nice clean database, hopefully, and then we run it through this kind of black box. I'm not going to lie to you, it kind of is a black box. There's a bunch of algorithms that run in the background and machine learning, that the word I used, to try to kind of find patterns in this data. And then what happens is it spits out this thing called a model. And a model is basically a equation per se that you kind of plug all these different features. The word feature means an element of your care. So for example, a feature might be your red blood cell count. That might be a feature of a model that I plug in, and then that gets an output. And so artificial intelligence gives us a model. And then what we do is we evaluate that model, and that model hopefully will help us predict outcomes and change patient care. That's kind of a roadmap for how we use AI in healthcare. This is really kind of the hierarchy of what we try to want to think about when we're thinking of artificial intelligence. So we have the electronic health record. That's what EHR stands for. That's no AI at all. And so basically that's a treasure trove of information from patients that could be used to create these AI models that I talked about. Then there's models that are really, really, really expensive to train. And when I say train, I mean you put it in the algorithm and then you make that model that I talked about. So they're very expensive to train, but then the output, the conclusion, the inference actually gives you very valuable information. So high cost to train, but very, very high cost and very tangible conclusions. high-cost training, low-cost inference, and then low-cost training, low-cost inference. So that's actually honestly the goal, is for us to be able to train a model that can give us a conclusion that is helpful, that doesn't cost that much. And that's the kind of the holy grail in artificial intelligence. How do we find something that is cheap to make and is cheap to implement? And that's been really hard to do in healthcare. And hopefully we can get there. So let me show you a couple examples of that. So high cost training. So very expensive to train this model, very expensive to kind of implement it into practice and make conclusions for. So you can have what we call multimodal training. So this word multimodal means that you have different types of data. And multimodal could be text, it could be audio, it could be your CT scan, it could be signals from your heartbeat, or you're wearing a watch and you actually have an accelerometer on it. We can have genetic data, we can have graphs, we can look at the medical literature, we can put all this stuff together, and then we basically can ask questions of the model and put all this different input in. And this has been used many times. It's been expensive to implement, but some patients have, actually Northwestern has one of these chat bots. Basically, if you, it's a lot of different companies have them as well, but like you go on a website and it's like, what's your question? And this whole computer basically walks you through and answers your question. That can be used in healthcare as well. You may see your doctor. It's kind of sometimes unnerving for patients when they first see it, but you might see your doctor now come in the room and put their cell phone down on the table and start talking to you. What's going on there is actually the computer in the doctor's cell phone is listening to the conversation and writing a note. And so that actually helps us a lot, because a lot of what we do is we want to spend time with our patients, but we're very limited because of the way healthcare in America is implemented. We have to go back and write a note and actually be able to kind of communicate. And so this actually is a very awesome thing that's happening, where basically the computers are writing the notes for us, so that we can spend more time with you. And so if you see your doctor do that, don't be alarmed. This is what's going on. And then we use this for kind of robotic procedures. This has been something that's been used a lot of times in urology and orthopedic surgery, using robots and AI to kind of really kind of tailor your surgery for you. I don't need to go through the rest of them, but we've used it in radiology, we've used it at the bedside. These are kind of really good things that are implementing a lot of different data and integrating it together to apply it to the healthcare system. But it's actually very expensive, and the output is also very expensive to run that model. The next thing that we think about is very expensive to train, but kind of once you do it, it's low cost to implement. So data to train these models are very difficult and expensive to collect. I have some kind of multimodal data shown here. So you can have the medical images, you can have genomics, we can have social media input, we can have medical records, and it all comes together into this healthcare database to run a model to try to really help us provide better care for you. This requires a very large staff to implement. It also requires manually, I have to go into the record and actually look at records and make sure that the data going in is correct, because bad data going in equals bad output, and we don't want to train a model that's going to provide you your care based on data that is not true, because then the output is not going to help us and would actually may hurt our patients. And so it also requires intensive validation. We have to keep looking at these models to validate them and make sure that they are actually doing what we think they should be doing. So the result of all of this is a trained AI model that can be used very quickly and affordably, but it's very hard to get to that point. It is very expensive. This is often proposed for developing it in a high resource center and deploying it into a low resource, low income area to help those places who don't have a thoracic radiologist who looks at someone with scleroderma every day, to kind of really understand what that ILD that Dr. Selvan is going to talk to you about really means, and how it relates to their underlying disease. So I mentioned the Holy Grail is to basically be able to train a system that is cheap and cheap to deploy. But how do we actually reach this point? So let's think a little bit about that. So the way we think about it in Northwestern and the way we think about it on the research standpoint is that the researchers, the clinical scientists the computer scientists that run these algorithms, they come to me and they say, what matters to you? What do you think about as a clinician? And I may tell them, as an ILD doctor, an interstitial lung disease doctor, I'm really worried about whether or not my patient's lung disease is going to progress. Can you help me tell me before it actually progresses, is it going to progress, okay? So then what happens is we have to collect that data. So patients are going to opt in and consent for that study to help us collect that data to answer the question. And so that's the next step is that we have the question and we have to get the patients to help us get the data for that study. Then we really want to have this data collection ideally without changing clinical workflow. And so the best place to get that would be in the clinic. And so if you come in to see me and we're talking about your lung disease and I order a CT scan, that is routine. That is not interrupting my workflow, but it's providing data for that question. So the best thing would be is to collect data that actually is part of standard of care and doesn't disrupt the workflow of the doctor or the patient's visit. Then we bring all that data into an AI model and we train it on reasonable tasks. This is just an example of a study that had been done to kind of look at a patient who had leukemia the blood pathologist looks under the microscope and sees this like weird looking white blood cell and says, okay, that's a leukemic cell. But actually a computer can look at it through an algorithm and actually look at different features of that blood cell and say, that's a leukemia. And so that would be a way that we bring data from a patient, put it into the AI model and allow the model to give us reasonable tasks, such as this leukemia diagnosis here. Then we need to take that away from where we actually are running the study, and we have to validate it on external data. So if we're looking at data in Northwestern, like I mentioned, there can be biases in these models because we're using a patient population that is specific to Northwestern. That might not be different. That might be different than our collaborators that we have at Yale. Some of you might remember Dr. Monique Hinchcliffe, who worked at Northwestern, might have been one of your rheumatologists that worked there. She actually is at Yale now and has helping us validate some of our data because actually the data at Northwestern may look different than the data at Yale. And we want to make sure that we don't want to just apply this model to people at Northwestern. We want to apply it across the country with patients with scleroderma. So it has to be validated multiple times on external data. And then once we do that, the goal is that I can bring you into my clinic and deploy this model in the clinical space. And so I brought up that question of whether or not your lung disease is going to progress. The goal would be that if you're on medication and I have all this data that's already there because we're already collecting it in the clinical space. The electronic health record could hopefully take all that data without me putting into it and tell me what the risk of that lung disease progression is. And if the risk is really high, I might talk to you about changing your medication. And we would do that before the lung disease progresses, ideally, right? So that's a good place to deploy the model in the clinical space. On the flip side of that, some of you and other patients with scleroderma might be on medication, and we don't actually know if you're benefiting from that medication, right? When do we stop medication? That's another great question because these medications that we use are often toxic. They require monitoring. You have to go get your blood drawn. And we don't know when to tell you when to stop them because we're afraid. And our patients are afraid because we know what it can lead to. But if I have a model that tells me that your risk of getting worse is actually close to like 1 or 2%, we might have a very different conversation than if your risk of progression is 90 to 95%, right? So really could change the way the conversations happens in the clinical space. So that would be the ideal situation with artificial intelligence in medicine. So where do these data come from that we train these AI models on? Okay, so it comes from a couple of different places. So let's talk about the collection process. So when we run a study, first we have to submit a protocol. we're using human subjects, we're using patients, and so we want to make sure it's very safe and that the patients are going to have the least amount of risk and the maximum amount of benefit. That it goes through what's called an institutional review board. So when you sign something for research, you sign a consent form that says that you understand the risks and you understand the benefits, and that goes through someone that tells us it's okay to run that study, and that's where we submit the protocol. Then we have to form a multidisciplinary team. It's not just me as a pulmonologist that's doing this. I can't run these models. I have no idea what they do. And so I need a computer scientist to help me out. I need Dr. Richardson to help me out from the rheumatology standpoint to really kind of help me say, what on the rheumatologic standpoint that patient is presenting with. And then we need, pulmonologists like myself who are going to talk about the lung disease if that's what we're interested in. So we need to form a big team. Then we collect the data. That's pretty straightforward. That can come from a lot of different places. That can be coming from a clinical trial where you're actually coming in and doing it specifically for that, or it could actually just be you consent us for use of your electronic health record, and it's just part of your standard of care. And so we collect that data. And then we develop our models, okay? And I mentioned that different ways that those models are developed and what they are. But unfortunately, this costs a lot of money. So part of that is that we spend millions of dollars doing this, and so we want to make sure that we're doing this in a way that is going to give us an output that is useful, and not an output that later on we're going to say, okay, that doesn't change anything. We just wasted a bunch of money. So the data collection process is very important. What does that look like on the institutional level? So we think about a couple different things on the institutional level. We think about convenience. So does that align with our current workflow? So can we conduct this and make it very convenient for the practitioner as well as patients, and as well as the institution? So we're not, taking up space in the hospital to collect this data where that is unneeded, and we're using it in a time that is convenient for everybody. We have to have a lot of trust, right? So we need to collect this data that in a process that requires steps that does not obstruct patient care, and that the patients trust that we're using this data in a very reliable way, in a very trustworthy way, so that there's no mistrust between the provider and the patient. And then it has to be valuable, right? The institutions, can they benefit from this? Not necessarily just money, but also can it be beneficial for patient care? Can it really move our programs forward, like the Scleroderma program at Northwestern? Can this really make us a care center that people really are excited about? Is it valuable to not just financially, but on every level? How valuable is that? And what about for you as a patient? So again, I mentioned simplicity. We don't want to bog you down. We don't want you to have to come into Chicago to give us that data if it's not part of your visit. So we really want you to be able to get us this data in easily and independent way, so that it's not really destructive to your everyday life. We want to be able to support you throughout the data collection process, and then eventually we want you to benefit from it, because that's the whole point. We really want patients to benefit, again, not just from money. There are studies that you may enroll in that will pay you to participate, but we want you to feel better, and we want you to not get worse. And so for patients, we really want the data to be beneficial on multiple different levels. Let's look at a very quick case study of how we can use AI in healthcare. So for step one, what we may do is that we'll collect, I use this word, multimodal data during the patient encounter. So multimodal, different modalities, different types of data. That might include imaging, laboratories, data from your health record, clinical notes. It might include listening to your voice and actually noting changes in the voice that might actually be a sign of respiratory difficulty. Or we might ask to wear a wearable sensor to really detect kind of your changes in your vital signs throughout the day. So these are data collected during a patient encounter. Then we use AI models to evaluate the data quality, completeness, and compliance. We then ask an artificial intelligence to give us an output, a model that'll help us. We input things from like clinical variables or large language models. You guys have heard of ChatGPT, right? That is a large language model. What that means is that it's basically just searching through the entire internet for all the words that you used and giving you an answer. And so that's a way that AI can give us what we need, and routing this through patient data and prioritizing the data. We can include clinical text, imaging reports, patient notes, EHR data. They summarize, and then we flag them. We basically say, okay, on this CT report, this patient now developed lung disease. And so we have to really flag it and tell AI what the outcome is, because AI doesn't know what the outcome is. We have to tell AI what the outcome is, and then the AI goes back in time and says, can I now, from that I know what the outcome is, can I, 5 years before, predict with the data I have the outcome 5 years later? So we have to tell AI what exactly the outcome is. And so it is still human dependent. And then we aggregate this data into dashboards, hopefully, risk scores, clinical summaries, actionable insights, and improve your care. Okay, so that's kind of like walking through how we use artificial intelligence. So how can we apply this to patients with scleroderma? So this is where I'm going to walk you through what we're doing at Northwestern with artificial intelligence to improve care for patients with scleroderma. So this is kind of a schematic of what we think about when we think about scleroderma ILD. I know that Dr. Selvan is going to talk to you about this right after me, but you might have heard this term before. So we think about interstitial lung disease. Interstitial lung disease, how we think about it right now, there's a lot of debate about this. We think about that the disease starts somewhere, I don't know where my pointer is, okay. So the disease starts somewhere over on the left side of the screen when you're looking at it, and it probably develops as an inflammatory process. It's we use anti-inflammatories to treat it. A lot of you might have heard of the name mycophenolate as a drug that we typically use for patients with ILD. There's another injectable drug called tocilizumab, also known as Actemra, which are both anti-inflammatory medications that are first line for scleroderma ILD. At some point, what happens is that the disease may develop what's known as a fibroproliferative stage. That is basically a scarring stage. And so we don't know when that lung disease goes from being inflammatory to scarring. And that actually is very important because that changes how we treat your disease. And I have absolutely no way of telling you with 100% certainty that you need to be on an anti-inflammatory or what we call an antifibrotic, which is something that prevents scarring. And so we are trying to use artificial intelligence to do several things that will help with care. We have all these, what these little things on top of this line right here are trying to represent are different data points. So we have data points from the electronic medical record. We have imaging. This little round thing is called single cell. Some of you might have had what was known as a bronchoalveolar lavage. It's kind of we put a scope into the lung and we can get cellular cells from the lung and actually phenotype them. We can describe them, and we can use that data to really understand disease processes. What we have here is that over here is the ILD diagnosis. But unfortunately, at some point, when we make that ILD diagnosis, again, we don't know if it's inflammatory, if it's scarring, and we might have made it a little bit late, and we have no idea where in the process you are and what medication you might benefit from. And so what we're trying to use is deep learning, machine learning models to replace this time loss, move the needle backwards to help us answer questions before the outcome happens. And so the outcome might be, are you going to die? Are you going to be diagnosed with interstitial lung disease? About 80% of patients with scleroderma who have interstitial lung disease have it on their first CT scan. That's a high number. So maybe a CT scan is the right thing. Maybe you don't need AI for that, but that still means that 1 in 5 patients are going to be missed if you only do one CT scan. And so we can use AI to say, are you going to develop interstitial lung disease later? Another thing we can ask AI is, are you going to develop a disease that looks more scarring that's going to progress over time? And if any of you have any friends or anything that have interstitial lung disease, you may have heard this term fibrosis and scarring. We treat that very differently, but unfortunately, we don't really treat that until you scar and get worse with the scarring, which makes very little sense, right? We would want to treat it before you start to scar and before the scarring gets worse, but that's unfortunately not. We can't predict that, and so we're trying to use AI to answer those questions for us. So we have this registry where our data is coming from called the Northwestern Scleroderma Registry. Some of you in this room may have consented to this already. Currently, we have almost over 1,100 patients with scleroderma enrolled in this registry. When I use the word person years, that basically means that for how long someone is in the registry multiplied by the number of people. So we have over 15,000 person years, meaning number of people times the number of years that we're following of data that in this registry that really hasn't been tapped into until recently. We have over 20 plus years of follow-up, so plenty of years of follow-up, and we have over 74 different clinical variables that have been collected during routine care in this registry. Some of these graphs here, so what I'm showing you here in panel A is I'm showing you the number of patients here and the number of years that they've been followed. You can see that obviously there's a lot of patients that just got enrolled, but there are patients going all the way out to 25 years that we followed in the registry. The number of clinical encounters that have been in this registry have exponentially gotten greater since the early 2000s. A lot of that has to do with a lot of effort from some of the people sitting over there, as well as our clinicians getting involved with this. In panel C here, you can see this is the number of active patients in blue in our registry. The yellow means that they're no longer following us. They may have, we don't know what happened to them. They're not following at Northwestern, but at some point they had been at Northwestern and consented to have been in the registry. And the red here are the number of patients in our registry who have unfortunately passed. And then in the last one here, we have the distribution of age by sex in our registry. And so the purple is females in our registry and the blue is males. We know that there are more female patients with scleroderma than male. And so it's not surprising that we have a lot more female representation in our registry. But we see that we kind of have a mean age here, an average age of in the 40s and predominantly female in our registry. A treasure trove of information that we really hadn't tapped into until recently. And so this is going to be, again, might be a little over your head, but I'm going to walk you through it. So scleroderma ILD, we tell everybody that they have ILD. And you might think, okay, it's one disease, but really it's probably not. A lot of people have different outcomes, and this is actually not an artificial intelligence model that did this. This is actually just routine statistics. What we did is, if you've ever had a breathing test, we measure something called the forced vital capacity. That's how much you can blow out in total. So the respiratory therapist sits there and says, take a deep breath in, take a deep breath in, now blow, 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 until you're completely empty, and that's called the forced vital capacity. And we follow this with patients with lung disease over time. And what we could tell from our registry data is that we have 4 different clusters of patients. And when I say the word clusters, it's basically the patients that look similar just simply based off of their breathing test and the trajectory over time. And we can see that there's a representation here in this, what we call cluster, where patients are doing really well and getting better. This cluster right here are patients that are doing okay and stay okay. These are patients that start out okay and get worse, and these are patients that are not doing so well and then get worse over time. And when we look at the outcomes in just these clusters, again, not artificial intelligence, just looking at this on a very kind of statistical level, we can see that there's a very big difference in mortality, meaning the amount of patients that die in each part of these clusters. The patients that die the most are the ones in this red cluster here who start out okay and get worse. And then we also can look at the rate of ILD in these patients. And so if you're in this different cluster or something, like, are you at risk of developing ILD if you've not actually already been diagnosed from that? So what does that mean for you as the patient? So if I've gotten like 2 or 3 or 4 different breathing tests, and I plug it in and the computer tells me which of these 4 different clusters you've now landed into, I can give you information about what is your risk of dying and what is your risk of having interstitial lung disease if you don't already have it. And that's just simple statistics. That's without using artificial intelligence. And so when we look at AI and we actually take it a next step further, we're going to ask it from our perspective at Northwestern. We have 3 different what we call tasks. So they're questions that we're asking artificial intelligence to do. The first thing we're asking it is, can artificial intelligence detect interstitial lung disease from routine clinical data? Now that, like I said, might not be a great question to ask because 80% of patients with interstitial lung disease and scleroderma have it on their first CT scan. But it actually is valuable because it actually can help us identify what we call biomarkers of disease. And that is basically something in your clinical data that tells us what your risk of interstitial lung disease is. And so now, we might not want to predict interstitial lung disease. That would be helpful for that 1 in 5 patient that doesn't have it on their first CT scan, but also it might help us be able to identify who's at higher risk and who we should be screening for interstitial lung disease more frequently. The next task we're asking is, can AI predict death in any patient? So I don't want you to think that we're just thinking about interstitial lung disease because, I'm a pulmonologist and that's what I think about, but we're asking any patient, even without interstitial lung disease, can we predict death in that patient and help augment their care at the point of care with the clinical data that we've already have? And then the third task we're asking the artificial intelligence to do is asking the same question, but now just in patients with interstitial lung disease. And so what we're hoping is that we're going to predict those that are at high risk for poor outcomes who may benefit from earlier tailored therapies for their disease. That is the key. We want to be able to treat your disease before it gets worse and not react to the worst disease, because that is, not the right way to handle medicine. There's they say that an ounce of prevention is worth a pound of cure, right? So we want to be able to prevent the progression and not try to cure something that's already happened. So let's look at what we've actually done already. So the task 1 that we asked artificial intelligence to do through our registry is, can we detect ILD through routine clinical data? So let me show you this. I know this is like, research and like there's like all these graphs up here, but let me walk you through this. Sensitivity on the left side of the screen is basically, if you have disease, how likely are we to predict it, okay? So that means how sensitive is the test means that if you have disease, am I going to be able to predict it? 1 minus specificity. Specificity is basically, if you don't have disease, how confident am I that the negative test is actually true? So how likely am I to exclude that disease? So this is the true positive rate, and this is the false positive rate. And we get this what's called an ROC curve, a receiver operating curve. And we look at what is known as the AUC, that is the area under this curve. And that tells us the test characteristics of that test. So the AI model that we created has this AUC of 0.83. And I put here what we think in medical literature is a good test. So, we're in the very good. I guess we should be excellent, but we're not right now. But we're in the very good range right now based on all the data that we threw into the artificial intelligence and the model that popped out of being able to tell whether or not, based on that data right now, if that patient has interstitial lung disease. Now, this took me forever to figure out how to read these, so I'm not going to expect you to know what I'm doing here. But what I want to show you, this is the model output, okay? So the machine tells me that this is what it's looking at, okay? And so the number 1 thing here is an anti-centromere antibody. Now, you can see there's a lot of red So that means that the red on the left, on the far left side of the screen means that a negative anti-centromere antibody, you probably have heard that term before, it's associated with limited skin disease, is actually predictive of not having interstitial lung disease. It's a negative predictor, but it's highly predictive of not having it. So this is kind of how you read this plot. And we got 20 different things that popped out as being very high features. But the thing that's cool is that it picked up things that we don't think about. So when I order a CBC, I get something called an MCHC. Now, that's a mean corpuscular hemoglobin concentration. I don't pay attention to that at all. But the machine is telling me that that actually is important. And so that's something that we can use artificial intelligence for, to find things that we are routinely collecting in patients at the point of care that might be important that I might not pay attention to because I don't think it's important. A chloride concentration. So that comes off of what's known as a basic metabolic panel that we get for your renal function or to monitor your liver function. A chloride concentration is important for the model. That's, again, something I don't typically look at when I'm perusing people's labs. And so what AI is helpful for here is maybe not to detect the ILD, but to tell me what's important that I might not be paying attention to already. So that's one of the tasks that we've asked at Northwestern with the data that we have in the registry. The next question we asked was, can we predict whether patients are going to die, any patient with scleroderma, based on in the registry? And we asked it to look at 1, 3, and 5-year mortality. And this is what we found. So I walked you through what an ROC curve is already. You can see that 1-year mortality, the area under the curve, we get into this excellent range. Awesome, right? Like, so we have a good model. But like 1 year, like that's not enough time really to make much difference, right? So we really want to try to predict later. So 3, 5-year mortality in patients with scleroderma, and our model actually did pretty well in what we're able to do with the data we already have. And I'm going to show you again this SHAP plot, which is again hard to interpret, but again look at these features here, and I want to highlight a couple. Calcium was the number one thing that popped out here to predict 1-year mortality. I've never looked at someone's calcium before when I'm thinking about whether or not they're going to die from their disease. Neutrophils, that's something we get off of a CBC that a lot of you probably get for your medication monitoring. RDW, you'll see that in multiple different models. I'm not going to show you all these, but in multiple different models, RDW is something that we get off of a complete blood count. It's the red cell distribution width. That has been a very strong predictor in the artificial intelligence models that we've been able to use through our registry as future death. And so these are just things that we don't typically think about, that the machine is telling us are important. And we already have it. So that's what's really, really cool, is that we might be able to kind of move the needle and use data we already have to help you help move your care forward in ways that aren't going to be disruptive to what we're already doing. It's actually kind of humbling to see this data come out and say, like, wow, I wasn't really looking at that, but it's actually pretty important. And then the last task I mentioned is whether or not someone with interstitial lung disease is going to have a high risk of death from their interstitial lung disease. And this is kind of the receiver operating curves, looking at how good the model has performed. We're kind of in that very good range. As we get further out, the model gets better. And again, same kind of thing, right? We're seeing things that we don't typically think about pop out as important. And so that's really the power of artificial intelligence in our care of patients. And through our research at Northwestern, we're trying to really kind of bring attention to this. And I'll tell you, these are things that are already in your chart, or something like your diastolic blood pressure. That's something that the medical assistant is taking, that I might look at and say, okay, it's normal. But even though it's normal, the variability might actually predict what is going to happen to you in 5 years. And so these are things that future might be put into a model pulled from your chart and actually show up on my dashboard and tell me what the risk is of you having an event in the next 5 years, and it might actually change how we today treat you, which is really cool. So in conclusion, AI is not the boogeyman. It's not, the Terminator is not going to come and create a nuclear holocaust on us based off of these models, hopefully. So AI is not the boogeyman. It can be used to do well. These machine learning algorithms can learn and adapt without following explicit instructions by using these algorithms and statistical models to draw conclusions by patterns in the data. I showed you some of those data points that came out, these patterns that I don't think about, but the machine has found is important. And so that's the power of AI. It's a powerful tool to predict inpatient outcomes for those with scleroderma. I showed you that data with or without ILD by integrating data that we already have through a simple model. And it uses readily de-identified data. I want to say that, de-identified. None of the data that goes in here is ever linked back to a patient from the patient electronic record to fuel these models and optimize our clinical decision making. And so in future directions, we've actually already validated these models. So I mentioned Dr. Hinchcliffe over at Yale. We've actually deployed this at Yale, and we had very similar results. And so this model actually is showing very similar things in a different population to get rid of that bias I talked about. The other things we want to ask are different clinical outcomes. I'd be very happy to hear from the audience what is important to you to ask the artificial intelligence system to try to help predict and then increase the applicability to our clinical practice. And then we also want to add other data into this. We have a collaborator who is in, does machine learning algorithms through CT scans, where basically we can feed CT scans in and see patterns in the CT that I might not pay attention to, very subtle changes on the CT scan to help make our decision making on whether to initiate or escalate or stop therapy for patients with interstitial lung disease. And if you're a patient in our program, please consider rolling in the registry. I already showed you something great that came out of it, and we're hoping that more can come out of it. I just want to do a real quick plug. We have some flyers over here. There's actually an event next week, so if you didn't have enough this today, there is an event next week that's going to coexist with the ACR meeting that's going to be here, the American College of Rheumatology, where we're going to showcase a lot of the things that we're doing at Northwestern. And so it's not just going to be me talking about lung things, but there will be rheumatology there, there will be GI there talking about GI issues, and there will also be pulmonologists like myself, both on the patient standpoint as well as on the research standpoint. So some of it might be over your head, but there is plenty of meat there for patients as well. And we actually have a few patients that came through our program that will be giving their own testimony at that meeting as well. And there's flyers over there, and the QR code to register, it's free, is on there. So thank you guys. And I don't know if I have time for questions, do I? No, I'm over.
We're a little over time, so we're going to roll right
I
into
talked a
Dr.
lot.
Selvin. That's fine. It was very informative. We appreciate you putting that together. That was really interesting. Thank you.